Hello to everybody and all the colleagues and friends. I'm very happy I had this opportunity to present this webinar activity for EMAS. And what we will discuss today is really how we have to handle the vicious circle between sexual pain and low sexual desire in postmenopause. Let's go and start with my disclosure of interest. I've been working over the years with all the major pharma companies in the field of hormones and hormonal therapy for postmenopausal women, and also in sexual medicine and contraception. Let's start with some introductory remarks. First of all, we have to keep in mind that sexuality is an essential component of healthcare of women at any age, because sexual dissatisfaction and psychological general well-being are tightly linked. There is a complex interplay of biological, psychological, and socio-relational factors which are involved in women's sexual health across the reproductive lifespan. This interplay may negatively affect the entire sexual response cycle, inducing significant changes in desire, arousal, orgasm, and satisfaction. And this occur, and we will focus our attention today into the menopause and also in the years after the menopause. Both age and declining sex hormones have detrimental effects on sexual functioning. And the two major symptoms we will address today is, on one hand, the significant increase in vaginal dryness and sexual pain related to dryness that we name dyspareunia, and a significant decrease in sexual desire and responsiveness. It's also very important to keep in mind that the partner's general and sexual health and quality of the relationship are as well important in contributing to the relevance of sexual symptoms in postmenopausal women. When we look at surveys conducted in postmenopausal women according to different methodologies, we realize that there are two major symptoms in sexual medicine. On one hand, reduced sex drive, and on the other hand, vaginal pain, dryness, or discomfort. And when we interview, for example, by a telephone interview, a group of European menopausal women in an age range between 50 and 60 years of age, we realize that these two major symptoms, low sex drive and sexual pain, are really part of the climacteric syndrome. And therefore, women entering our office for menopausal consultation are really willing to address not only the issue of hot flashes and mood change and other aspects of women's health and menopause, but they would love to discuss also about sexual health and well-being. Menopausal transition and sexual function seems to be strongly linked also in longitudinal population-based study. The data I'm presenting here is a very famous paper by an Australian group. The leader author was Lorraine Dennerstein, and she was able to show very clearly to us that over time, in a group of Australian women between the age of 45 and 55, and they were followed over 11 years and more, we can observe a significant link between vaginal dyspareunia, which increases over time, and libidos, low sex drive, that decrease over time. These two major dimensions of the sexual response are also linked to a significant decline in overall sexual responsivity, overall reduced sexual frequency, and extremely interesting, an increase in partner general and sexual problems. In a more recent study that we conducted in Europe, the acronym of this survey was the Revive Survey, Real Women's Views of Treatment Option for Menopausal Vaginal Changes. That was a country-specific comparison of postmenopausal women's perception, experience, and needs. Together with a group of friends, especially Santiago Palacios and Nick Panay, we were able to demonstrate very clearly that in across Italy, Germany, Spain, and the UK, when we ask to women, how was your sex drive? How was your libido? Before a diagnosis of vulvovaginal atrophy, and now that you are suffering from vulvovaginal atrophy, you may see very clearly from the figure that we observe a significant decline of sex drive in women suffering from this condition. And we will see in a few minutes that this condition, vulvovaginal atrophy, is strongly related to sexual pain, so to the item of dyspareunia. And when we interview this but in women, they are into a stable relationship, so they have a stable partner, but also in women, they do not have at present a stable partner. So these two dimensions are strictly linked in our postmenopausal women. And just to understand why this is happening, I would like to show this cartoon that I produced upon the theory of Rosemary Besson on the circular model of female sexual response. You see here all the different dimensions of sexual response in women, and we can recognize what we name spontaneous sexual drive, and that is strongly related to a biological roots of desire that is strictly related to, we will see in a minute, to the androgenic environment. But you see that in women, motivation for sexual function and behavior is also related to some psychorelational aspects, what we name emotional intimacy. In any case, even if you enter the sexual response due to your hormones or to your emotional and relational aspects, when you enter this circle, you process sexual stimuli from internal sexual stimuli and external sexual stimuli from your partner, but then you develop, of course, arousal and genital response that include some genital aspects that has to do with lubrication and sensation, so with your body, your vulva and vagina, and then you have orgasm and satisfaction if you are feeling good. But unfortunately, if you feel sexual pain, both dyspareunia, meaning sexual pain during intercourse, or even you feel non-coital pain, there will be that vicious circle I said at the beginning. Because if you have pain, sooner or later you will have a blunted mental response in terms of sexual behavior, and you will reduce your enjoyment for sexuality, and therefore sooner or later you will develop low sexual desire. And we will see in a minute that it's very common to feel and to experience dyspareunia during postmenopause as a consequence consequence of a significant change in the anatomy of the function of the major organ that is involved in coital activity, that is the vaginal canal. The importance of vaginal health and the association of vulvovaginal atrophy in terms of sexual function and dysfunction in postmenopause has been explored in many studies. We see here a study that I like very much because it's simple, but it's very elegant. That is the MAP study. Sexually active postmenopausal women, more or less 150 from the menopause epidemiological study that was a cross-sectional population-based study of women between 40 and 65 years of age in North America, in the US. And you see that vulvovaginal atrophy was defined as one or more of the following symptoms: vaginal dryness, itching, irritation, pain on urination, or pain or bleeding on intercourse. Women they were also interviewed with a very simple but clear-cut instruments, the Arizona Sexual Experience Survey, that was used to define female sexual dysfunction. Very interesting in this paper, the prevalence of vulvovaginal atrophy was 57% in this population of postmenopausal women, and the prevalence of female sexual dysfunction was 55%. But what it was extremely interesting to observe is it was that women with female sexual dysfunction were more or less 4 times more likely to have vulvovaginal atrophy than women without female sexual dysfunction. And this is extremely important because it means that in order to prevent female sexual dysfunction in postmenopausal women, it is mandatory to address the issue of vulvovaginal atrophy across menopause. The importance of VVA symptoms, vulvovaginal atrophy, interference with sexual life, and other dimensions was further explored in the study I mentioned before, the REVIVE study we conducted on a sample of more than 3,700 women in Europe in an age range of 45 and 75 years of age. And what we showed in that survey is that VVA symptoms are capable of interfering with sexual satisfaction, sexual spontaneity, intimacy, and relationship with the partner more or less in 3/4 of the study sample. But it's interesting to observe as well that other dimensions of well-being are affected: enjoyment of life, sleep, and also other everyday activity may be affected by symptoms of VVA. So this issue is relevant to sexuality, but also to other dimensions. They are important for social and relational life of women. When we look at the number we observe in the clinical practice, so not only surveys, but real patients, they come to menopause clinic. I like to show this paper we published many years ago. It was one of the first paper investigating the concept of comorbidities among different sexual symptoms in real life. This study included at that time 355 postmenopausal women between 46 and 60 years of age in 10 Italian menopause clinic. And what we observed at that time is that vaginal dryness was present in more or less half of the sample, 45% of women, Dyspareunia saw sexual pain in more or less 30%, and low desire and lack of mental arousal in 22%. And even poor orgasm and satisfaction was more or less present in 45% of the sample. So these early data demonstrate quite well that there is a strong comorbidity among different sexual symptoms, and a sexual symptom cannot be studied in a vacuum alone, but we really need to put into the perspective of sexual function overall. We further explored this issue later on, and in 2010 we published another paper. It was a cross-sectional study conducted in 138 women between 40 and 60 years of age in my department. We interview women with a validated questionnaire in order to measure different dimensions of sexual function and behavior. The female sexual function index questionnaire, addressing information on desire, arousal, lubrication, orgasm, satisfaction, and sexual pain. And we consider women across the menopausal transition: early perimenopause, late perimenopause, early postmenopause, according to stroke criteria. Even though these data were cross-sectional, they really confirmed the one I showed you before from Lorraine Dennerstein, that there is a significant change between early perimenopause to late perimenopause and early postmenopause in the entire sexual function, not only in one dimension or two dimension on sexuality. And low desire, low arousal, low lubrication, low orgasm, low satisfaction, low sexual and higher, sexual pain may be significantly observed up to 3 years after the menopause. Interestingly enough, when we analyze the predictors of sexual function in early postmenopause, that was the bigger cohort of women we investigated from several angles, considering many variables, including hormones, mood status, eating disorders, marital adjustment, and so on, we were able to identify both biological variables such as estradiol and DHES, so both estrogen and androgen biological roots of sexual function and behavior, but we identify as well also a mood variable such as uh, state anxiety as major predictors of developing a sexual dysfunction over time. I think this study was quite relevant to understand that we have always to take into consideration both biological and psychological aspects when we address sexual symptoms at menopause. And most importantly, we have to address the estrogen route of sexual response and the androgen route of sexual response. So we start with understanding the vicious circle of dyspareunia on sexual function and behavior. This is a cartoon I developed some years ago to help doctors to understand how hormones are important. So hormonal changes are important at menopause in impairing vulvovaginal receptivity, so the genital response during sexual stimulation, and how dyspareunia may be a leader symptom. Of course, what is important in terms of preventing the vicious circle? What I name the time effect, meaning that we have to address very early in our menopausal clinic the presence of sexual pain, of dyspareunia. Why this? Because if we address very early, we can prevent the negative cascade of impaired orgasm, reduced satisfaction, and a secondary low libido. This low libido then may lead to low sexual activity, to couple dysfunction, may be related as well not only to sexual pain due to vulvovaginal atrophy, but also to other psychological dimensions such as anxiety, so the fear of feeling pain during sexual intercourse, and some other physical component of the sexual response that has nothing to do with uh, vaginal atrophy, but they have to do, for example, to hypertonic pelvic floor because the fear of pain inducing women a strong contraction of the levator hernia muscles, and therefore women they don't feel only deep dyspareunia because the vulvovaginal response is impaired, but they always also feel introital dyspareunia due to hypertonic pelvic floor activity. So sooner we address dyspareunia symptom, better we can prevent sexual dysfunction in postmenopausal women. And indeed, how we can do and why it's so important to revise with you the positive effect of estrogen on the vaginal tissue. Because we know very well, this is a famous cartoon that a good friend of us, David Archer, published some years ago, addressing the vital role of estrogen on vaginal tissue. He was able to summarize this idea very well. Low estrogen around the time of perimenopause reduce the thickness of the squamous vaginal epithelium, change the structure of the vagina, decreasing the application, the rugae we have in the vaginal mucosa and dermal tissue. You have a significant change in the appearance of the tissue. The pink color is lost, so the vaginal mucosa is pale, and we miss as well the moisture, the natural moisture of the vagina. But without estrogen, we observe also to significant change in connective tissue, mainly in the fragmentation of elastin and in the hyalinization of collagen. So these changes are extremely relevant to the functional anatomy of the vagina during the response, the genital response to sexual stimuli. But we have also other changes in the vaginal environment, what we name the microbiome of the vagina. We change the glycogen formation. We have a significant reduction in the production of the Doderline lactobacilli that convert the glycogen, and so we have a significant decline in the lactic acid that is capable of regulating the vaginal pH. And therefore, we can develop atrophic vaginitis, meaning that we are not protecting anymore from the bacteria that can come from the gut reservoirs, and so we may have a colonization of bacteria, especially E. coli, that can give us many problems in terms of recurrent vaginitis and recurrent urinary infection. But hormones are capable as well to influence other aspects of vaginal function. So not only the vaginal mucosa and the vaginal environment, but also other aspects of the sexual response, because we know that sex steroid hormone, they may act thanks to genomic and non-genomic activities On cellular function, many cells, not only epithelial cells influencing emulsification, keratinization, and permeability of the mucosa, but also the blood vessels, so the growth and the vasoreactivity of these vessels, they are so relevant to the neurogenic transudate that give us lubrication and blood flow congestion related to genital arousal and lubrication. And we know quite well that when you don't have this lubrication and congestion, you develop significantly dyspareunia. So not only because your vagina is little, but also because your vagina is not perfectly functioning during the sexual stimulation. And it's very important to remember that we have an impact of sex steroids also on non-vascular smooth muscles, so growth and response to neurotransmitters, and on neurons synthesis and release of neurotransmitters during the sexual response. They are helping all the process of lubrication and blood flow. We mentioned sex steroid hormones, so not only estrogen, but we know also androgens. This is a very nice study I pick up from basic science in order to demonstrate to everybody very clearly that we don't need only estradiol to have a perfect sexual response at the periphery, but we need only androgens. This is a study that was published a couple of years ago by an Italian group on the animal model. They studied several biomarkers of genital response in terms of arousal and lubrication at the level of the vagina, but most importantly at the level of the clitoris. We know indeed that the genital response is regulated not only by the vagina, but also by the uretro-clitoral complex, a structure that is strongly dependent from testosterone. So when they analyze several biomarkers, they are so important for the congestion of the penis in the males, they discover that also the female clitoris is responsive not only to estradiol but also to androgen, and testosterone improves the relaxation of muscle cells throughout the nitric oxide CGMP pathway, and both testosterone and 17 beta estradiol are necessary to maintain a functional contractile and relaxant machinery in the clitoris. And to me, this is extremely important to understand what happened into the menopause in women and why we have to consider both estradiol and androgenic milieu, because this new concept may provide support for the concomitant use of estrogen and testosterone during the treatment of sexual arousal disorder in women. So another link between mental desire and mental arousal and genital response and genital arousal, because sexual arousal disorder to me they are related to both a hormonal imbalance or insufficiency in terms of estrogen and androgens. And this is the reason why a very recent review article spoke about not only on the role of estrogen but also on the role of androgens in nourishing female tissue structure and function, so relevant for the sexual response. And we realize that androgens are as well important, not only for the outer part of the vagina, the clitoris, the urethra, and the vestibule, as we have shown in the animal models, but probably also to the pelvic floor function that contribute to the genital response in women. In this cartoon, in this review, you see for the first time a new term I want to discuss a bit with you now. That is the genitourinary syndrome of menopause. What it is genitourinary syndrome of menopause in comparison to vulvovaginal atrophy? First of all, we have to think about that the concept of urogenital aging is there since a long time. This is a very famous study I like very much when I was at the beginning of my career. Gloria Bachman published this study that was very important to show that when we deal with postmenopausal women, we do not deal only with dyspareunia, but we deal with a huge cohort of symptoms addressing, interesting, sorry, the sexual function overall. So we deal also with sexual desire in terms of masturbation, foreplay, oral sex, and sexual function, fantasy, and so on. And she was one of the first authors mentioning the importance of addressing also the gynecological part and not only the vaginal part, but also to underline the importance of treating very early the issue of the vagina in order to prevent something that is within the brain, such as an impairment of sexual fantasy and mental behavior of sexuality. And this is a very important concept to understand VVA and GSM. Because you see from this cartoon that VVA is something that has to do with the anatomy and the function of the vagina, strictly related to what is happening in terms of lack of hormones at the time of menopause. You have in the cartoon on the left side the very healthy pink vagina, very nice vaginal fornix, uh, nice vaginal wall, nice vaginal arteries, very healthy. All the rugal folds in there, and the genitals also, the outer genitals, very healthy. And then on the right part, you see what is happening. Loss of the vaginal fornix, thinning of the vaginal wall, what we mentioned before, the reduced blood flow to the vagina, loss of rugal folds, decrease in vaginal length, and atrophy of labia minora and labia majora. So we have a narrowing of the vagina. So this is what we know. It's something that has to do with the anatomic condition of the vagina. But if we want to be modern, probably we have to include other dimension of women's urogenital and sexual well-being. They are related to the atrophy, so they are related to menopause and the change in estrogen, but they are related also to the change of androgen, and they are related also to other aspects of genital well-being that involve the urethra, the urethral meatus, and the vulva, the vestibule, and other tissue. Indeed, you see that when we deal with the constellation of genitourinary syndrome of menopause, we have to do not only with vulvovaginal symptoms we are used in the menopause field, vaginal dryness and burning and itching, but we deal as well with sexual symptoms, dyspareunia, but we will see not only dyspareunia, all the dimension of sexual function and behavior, and also with urinary symptoms. These symptoms are related not only to estrogen and androgen changes occurring across the menopausal transition and with the aging process, but also to the age itself, so to the change of women health in terms of bodily and mental function. All these symptoms have an impact on quality of life and relationship and may be present, sign and symptoms, not at the same time. And another very important aspect of genitourinary syndrome is that you may have the symptom, but in order to make a diagnosis, you need to be sure that these symptoms are distressing for your patient. So symptoms need to be bothersome. So maybe you have the anatomical condition of VVA, vaginal atrophy, but if women, they do not complain about the symptom, and maybe the condition is not treated because women, they do not report really these symptoms in practice. And we have to consider which kind of symptoms usually we address in our practice. You see, we usually address vaginal dryness and dyspareunia, and you realize that these are two main symptoms of VVA. But some women, they do not report dyspareunia when they have vaginal dryness, maybe because they are not sexually active. So when we address the issue of VVA and genitourinary syndrome of menopause, we really need to address also sexual behavior, not only the anatomical condition of VVA. And probably we have to explore the sexual response in a broader, with a broader approach. And you recognize as well that there are some symptoms that comes from urinary health, such as, for example, involuntary loss of urine that may be present in 30% of the subject. And this is a series of women. They were reporting VVA in a survey conducted in women between 55 and 65 years of age. However, there is a challenge when we consider genitourinary syndrome of menopause. This is a nice review article that was published by Gandhi in 2016, and you recognize a bunch of symptoms. They are including so many aspects of genital, urological, and sexual health that is a bit probably too much. So not all these symptoms, as you can imagine, they have to do with VVA, but they may have to do with other conditions. And we really need to be smart enough to recognize what is related to estrogen deficiency, what is related to androgen deficiency, and what is related to other conditions. They are there and they may affect genitourinary function in women. Think about vulvar pathologies, pelvic floor abnormalities, uterine, ovarian, and other gynecological and urogenital conditions. And why this is relevant? Because we need to avoid an oversimplification of treatment of genitourinary syndrome of menopause. We have to keep in mind that with hormones, we can treat vulvovaginal atrophy, but maybe we cannot treat other condition that has to do with, let's say, and we will see in a minute, low libido, or, for example, pelvic floor dysfunction of or other urinary symptoms. And just to give you an example, also for VVA, it's so important to be smart enough to make a differential diagnosis. It's not everything due to estrogen and androgen deprivation, but we may have as well infectious disorders, irritant or allergic vaginitis and vulvitis, vulvovaginal dermatosis. Think about lichen sclerosus, erosive lichen planus, and other vulvitis. As well, we need to consider hypertonic pelvic floor muscle dysfunction, as I said before, and also painful bladder syndrome, interstitial cystitis. They may be related to sexual pain and symptoms associated with VVA, but also vulvodynia and pudendal neuralgia. And now we move to the other side of the sexual response, the one we mentioned at the beginning: low sexual desire, impaired motivation in sexual response. We said hormones are important within the central nervous system, And we realize, and I will show you in a minute, especially androgen, testosterone, and DHEAs are two hormones that have been somehow related to low sex drive. But in women, we know from the Basson model that impaired motivation may be due also to emotional intimacy, low emotional intimacy, and relational problems. And with this cartoon, we mirror the cartoon I showed you before on Dyspareunia. We have to be capable in clinical practice to address the issue of the leader symptom and time effect. Why we need to be good in that? Because we need to prevent the consequence of low sex drive. Because if you have low sex drive, you may have dyspareunia. We may have low sex drive, as I told you, when we have androgen insufficiency. This is a study that include different symptoms related to low desires, low sexual motivation, fantasy, enjoyment, arousal, and genital vasocongestion, what we name androgen insufficiency. We know that there is absolutely useless to measure low testosterone in the blood, but we have to interview our patient and to try to understand, according to the symptoms they report, if maybe they have some kind of androgen insufficiency. We have women, they have more frequent vasomotor symptoms, insomnia, depression, headache, and a cluster of symptoms of sexual dysfunction, but also poor bone mass, poor muscle mass, and poor quality of life. Sue Davis was smart enough to summarize all the causes that we believe are a cause of low testosterone in women. Aging, because it's physiological with aging to observe a decline of the androgenic milieu, but also primary ovarian insufficiency, adrenal insufficiency, other condition, but the most common iatrogenic condition is for sure bilateral oophorectomy with or without hysterectomy. So when we have women, they have both estrogen and androgen deficiency, it's very important to go back to the past. And you see from this beautiful cartoon that more than 40 years ago, again, the group of Gloria Bachman with her mentor, Sandra Leblum, they published that even vaginal atrophy that is so strongly related to estrogen is as well strongly related to androgen. Why? Because it's related to being sexually active. So to keep on going with your own desire, with your own libido. And they use the term use it or lose it in terms of vaginal health and well-being. Why? Because when they compare sexually active women with sexually inactive women, they realized that women that were sexually active and they had a significantly higher level of androgen, testosterone, and androstenedione at that time, these women they had less vaginal atrophy. And so this is another piece of history in research that link the genital to the brain, to the desire. And just to end this part and to go to the conclusion, we have to keep in mind that when we deal with low desire, and therefore we deal with genitourinary syndrome of menopause, we have to understand if low desire it's really a symptom, it's really a dysfunction, is related to distress for women and is not just normal, because we know very well that it's absolutely normal during the life cycle, according to partner health, quality and duration of the relationship, and other life events, to develop what we name hyposexual desire disorder, or with the new terminology, female sexual interest and arousal disorders. What is this? Is having at the same time low desire, low mental arousal, and genital arousal, and according to distress. It's not an easy diagnosis in sexual medicine, and especially in the field of menopause. Why? Because there are many causes. They can be associated with low desire and interest in women. And one of these causes is for sure entering menopause, among other conditions. We have some screener out there, as the one I show you now, decrease sexual desire screener, and we have to ask our patient some very easy question in order to understand if it's really hypoactive sexual desire disorder, or maybe other conditions such as, for example, mood disorder, medication, and so on, are related to the level of sexual desire and interest in our patient. Only if these conditions are excluded, indeed, we may talk about hypoactive sexual desire disorder. So, in my opinion, it's very important that we keep in mind that even though a lot of women menopause report having these two major symptoms, dyspareunia and low sexual desire, so more or less, as I said at the beginning, 40-50% of women, only a few of them, they report distress, and they are motivated to be assessed and treated in real life and practice. And of course, as doctors, we need to be proactive, but we don't have to over pathologize women. There are some women that just want to receive adequate counseling, and maybe they have the symptoms, but they don't feel that these symptoms are distressing for their own life. Indeed, distress is strongly related to age. We have this very nice data out there in the US suggesting that distress is low after 65 years of age. So maybe you have the condition of VVA, you have vulvovaginal atrophy, but you do not report sexual pain because you believe that sexual function is not so relevant to your own life anymore. Maybe you have low desire, but you don't have hypoactive sexual desire disorder because you feel that your intimacy with your partner is based on other aspects, and you may be perfectly satisfied with your intimate relationship, even though you have low desire and some kind of VVA. And this is the reason why, as you can see very clearly, for sure, menopause play a major role in sexual symptoms associated with distress. But when we look at the number suggests that it's around 10-15% of perimenopausal women. They are keen to discuss with their doctors and to take some kind of treatment to address their own problems. It's important also to keep in mind that all the different diagnoses in terms of sexual dysfunction, so low desire associated with distress, low arousal associated with dyspareunia, and even poor orgasm, are strongly related to your general health and to having a partner. So having a partner is a major determinant in menopause clinic in terms of motivation to be treated. If you have a current partner, you are more or less 4 or 5 times more likely to report sexual symptoms associated to distress. And this is the motivation you have to address symptoms. But a last word on the couple. I think relational problems are as well important. And as I told you, we don't have to think that hormones can fix everything. This is especially important when we deal with low desire, because we have to consider that there are other aspects that have nothing to do with hormones. They may be involved in low desire, sexual dysfunction in partner, interpersonal conflict, extramarital affair, cultural difference, and other personal and intrapersonal and interpersonal aspects. So, how we can conclude this vicious circle between dyspareunia and low desire? As doctors in the menopause clinic, we have some strategies to maintain sexuality in menopause. First of all, we really need to educate our patient to be aware that sexual symptoms are there, to give them permission to discuss. And when we explain what is happening with the aging process to both men and women, we are doing a basic counseling that will help our patient to understand the impact of many factors, not only menopause, on sexual health and well-being of both men and women. For sure, we have to recognize the signs and symptoms of VVA and hypoactive sexual desire disorder. We may do questionnaires, of course. We can do a gynecological examination to recognize the sign of VVA, and question to recognize if women they are strongly distressed by sexual symptoms. We have to promote general health in terms of lifestyle recommendation, prevention of disease, medication use that may be related to sexual symptoms, and we have to pay attention to the partner as well in order to provide individualization of treatment that will include, of course, hormonal strategies according to women need, risk benefit profiles, and so on, as we usually do in uh, our menopause clinic, but we have to consider also non-hormonal compounds and psychosocial intervention. What we have in order to manage genitourinary syndrome of menopause, all doctors in the field of menopause know these hormonal strategies. I don't want to go throughout this. We know that we have topical and systemic hormone therapy. We have a specific treatment for sexual symptoms, such as, for example, tibolone, because it's a drug both acting on estrogen and androgen. We have a new serum of Spemifen, especially designed for VVA. We have a new future treatment in Europe, vaginal DHEA, and we have other hormones. But what I want to mention here that we can do some good by treating our patient in terms of sexual function and behavior as an overall circle in terms of sexual medicine. Let's see this data. We published some years ago on the use of a very simple treatment for VVA, such as local estrogen therapy. And you see from the closer survey conducted both in female and men that we may improve a sexual life, overall sexual satisfaction with your partner. So when you treat the VVA with a simple tool such as local estrogen therapy, you may improve not only sexual pain, but the entire sexual response in your patient. So we really need to be proactive, ladies and gentlemen, in order to address sexual symptoms such as dyspareunia related to VVA, because we realize from the Revive survey that if you discuss VVA symptom with your healthcare provider, you can really improve your ability to treat with any kind of treatment. We consider not only hormones but also lubricants and moisturizers. If you treat them because you have an effective communication with your patient, you can really improve life and well-being of your patient. We don't have so many treatment for hypoactive sexual desire disorder alone. We have to include, as I said, a psychological intervention. And the only treatment that is published in the literature with some kind of level of evidence is testosterone therapy. But as you know very well, we don't have testosterone therapy in our hands for women anymore, and we really need to have an approach that is an off-label approach using testosterone drug designed for men. What is very important and the key message of my webinar that is always uh, we need to have an integrated biosocial approach in our clinical practice, and of course we are maybe gynecologists in the office. We are doctors from other specialties addressing menopause medicine, but we always need to be also a bit of psychologist in order to address the vicious circle of dyspareunia and low desire. And being a member of the board of the International Menopause Society, I wait all of you at the 16th World Congress Menopause of IMS in Vancouver next June. And I thank you very much for your attention together with my menopause team at the University of Pavia in Italy. Bye bye.
Okay, thank you so much, Dr. Nappi. That was really interesting, your presentation. Now I think we still have a few minutes. We are still welcoming one or two questions from the audience. So if you have any questions, please do not hesitate to type on your question panel so we can ask Dr. Nappi. Hello, Dr. Nappi, are you still there?
Yeah, I'm here, and I gave many information. I hope
Okay,
people.
yeah. Oh, okay, so we have a not a question, but just a hearty thank you from Alka Racing. Okay, I might not be a doctor, but I do have a question actually. Is there any way to avoid dyspareunia and low sexual desire before we get to the menopause stage, or is it like automatically everybody will get it at one time?
VVA and is a chronic condition, and you may develop this condition just because you are entering menopause and with age. But I believe that we should treat the condition when it's really relevant for women sexual health and well-being. Otherwise, we have to think about that VVA, it's like getting wrinkles on your face. Everybody will put a cream to prevent wrinkles. Of course, everybody can put something to prevent the change in the vagina. But having sexual dysfunction is much more than that. It's just more than wrinkles in the vagina. And so, of course, we can be on the side of people that will say we have to prevent, so we really need to treat before signs of VVA appear in the gynecological consultation, because sooner or later you will develop. On the other hand, we have to be aware that there are many women, they do not complain about these symptoms. Maybe they have the vaginal atrophy, but they will develop other kind of symptoms, let's say urinary symptoms when they are getting older, and at that time they will ask for our help. So when women they enter the office and they want to be treated, this is the right moment to address. The most important thing, in my opinion, is giving women education in order to understand that when they have that symptom, before thinking that maybe it's just an infection, that it will go away, and so on, or maybe it's something in the relationship, you have to address the importance of menopause. But it's also true the other way around. Don't attribute to menopause what is within your relationship, for example, because otherwise you will fail in really being effective to your patient. So we really need to think about the biopsychosocial model in order to really address sexual dysfunction in women. Otherwise, we will just treat the symptom.
Ah, okay, thank you so much. So we have one question here from Richie Yumdo. The question is, how long can you give topical vaginal estrogen?
We can give a topical vaginal estrogen as long as they are needed. Of course, as you know very well, we have a safety data usually in studies conducted up to 12 months. But as soon as you control your patient regularly. There is no need to stop local estrogen therapy if women they will benefit from the treatment. And according to guidelines, both from EMAS and IMS and even North American Menopause Society, we can safely use the low estrogen therapies within the vagina as long as they are needed. And you, for example, do not need endometrial protection with the progestogen because these compounds act locally and they are not contraindication to their use apart in estrogen dependent oncological disorders. But even in that case, sometimes guideline they say you should discuss with your patient and you should discuss with the oncologist. So don't be afraid of using very low dose of estrogen to relieve VVA symptoms.
Okay, thank you so much, Dr. Nappi. Unfortunately, we don't have more time, and there's no more questions, so I think we can wrap up. Do you have anything else to share before we wrap up, Dr. Nappi?
I just want to say bye bye to everybody and to think every day in the office how is important sexual health for women. Bye bye.